welcome. This is actually one of my most favorite events of the year. And I just want to welcome Anne here as well, and McArthur and Dana, and they'll be speaking later on. I also, but I'll leave this later on. I just wanted to say thank you to Laura. All right. So welcome everybody to the academic presentation of the 2023. I thought we in 2024. And then Neil McArthur Research Award. My name is Lahana Tabani. I think I recognize everybody's face. I'm the Vice President Research at St. Joe's. I'm also the Scientific Director of the Research Institute. Like I say, honestly, this is one of my favorite events of the year. And it's always fantastic to actually have this presentation because you really get to see the depth of what colleagues are working on. And I hope you'll also feel the same after the presentation. We'll hear from Lawrence today. And I want to welcome Lawrence's family as well, Mira and the kids. Welcome to St. Joe's. This is where, Lawrence really plays in everybody's backyard. Lawrence will be talking about empowering HIV care, navigating mobile health solutions, and tackling drug resistance among HIV people. Following the presentation, I hope you'll join us in the lobby for some refreshments and connections with colleagues as well. So please do stay behind after the presentation. So before we begin, let's take a moment to reflect on the lens on which we are privileged to serve our community. We at St. Joe's Healthcare Hamilton recognize that the lens on which we provide care, learn, and conduct research are the traditional territories of the Mississauga and the Haudenosaunee peoples. For thousands of years, the first people sought to steward the precious resources and share this land with others. These territories are the subject of the Dish with One Spoon, Wampum Belt Covenant, an agreement between nations to peacefully share and care for the lands around the Great Lakes. At St. Joe's Hamilton, we pledge to continue to work together with our Indigenous peoples in building a more just society where their gifts and those of all other people are nurtured and honored. I just want to stop for a minute and reflect on this. It's become a tradition as part of our commitment to truth and reconciliation to actually, say a few things about land acknowledgement. But I want to focus on the key word in it, which is sharing, to share the land. Sharing is about kindness. It's an act of kindness. You can't share unless you're kind. And I just wanted to say, as I reflect on that word sharing, we now know that to be kind, it takes 40 seconds to be kind to another person. The second thing is we know that kindness doesn't only benefit the person who's receiving it or the person who's giving it, it also benefits those who are witness to it. So I would say, let's continue that culture because that's part of who we are at St. Joe's, which is cultivating kindness and compassion. All right, ladies and gentlemen, please welcome Dana Rice, Vice President, Development at St. Joe's Healthcare Foundation, who will introduce the award and the McArthur family. Dana.
Thank you, Lahana, and thank you for using that very nice picture of me. That is me. On behalf of St. Joseph's Healthcare Foundation, I would like to thank the Research Institute and Laura and her team for coordinating the Anne and Neil McArthur Award selection, which is a good process, and today's event as well. The prestigious Anne and Neil McArthur Award was funded in 1999 by the McArthur family to recognize an internationally renowned Canadian researcher whose area of study is also a focus of research at St. Joe's. Anne and Neil McArthur knew the transformational power of research to advance healthcare innovation, and this award recognizes the achievements of the recipient as a world-renowned researcher in their field. On behalf of St. Joseph's Healthcare Foundation and the Research Institute, I would also like to thank the McArthur family for their continued support of research at St. Joe's. It's because of you that we continue to offer this award and have this great event. As an academic health sciences center, we're grateful to have so many outstanding researchers who are truly leaders in their fields. We are proud to acknowledge all of the recipients of the Neil and Anne McArthur Award, including Dr. Tabane, the portraits of which are displayed in the hallway outside this auditorium, and we're happy to include this year's recipient there. The Anne and Neil McArthur Award is a testament to their dedication to excellence and in leading groundbreaking research that ultimately improves lives in our community, across Canada, and throughout the world. And now, to say a few words and introduce the 2023 recipient of the Anne and Neil McArthur Research Award, please welcome the granddaughter of Anne and Neil McArthur and namesake Anne McArthur.
Thank you and good afternoon. So as mentioned, my name is Anne McArthur, and I haven't always loved having the same name, and it's actually both of my names are from family names. So my first name is actually Marjorie, which is my mom's name. So every other generation goes by their middle name. But today I have to say, and the legacy that my grandparents have given me and my family, and to be able to carry her name and be able to present here today as Anne McArthur is really something that I am pleased to do. And the Anne and Neil McArthur Award was established over 20 years ago. We couldn't remember what the actual date was, so I'll have to remember that for the future. And I've been privileged to actually attend many of these events when it started out as a dinner and it has now moved into this format. It's my annual reminder that the foresight that my grandparents had and valuing the importance and the power to advance healthcare innovation and powerfully impact lives through healthcare research. The award celebrates the achievements of researchers recognized by the international community for their work and whose field of research is a focus at St. Joseph's Healthcare Hamilton and the Research Institute of St. Joseph's. This award demonstrates the kindness and generosity my grandparents shared with the Hamilton community that I feel so lucky that I both live and work in, and am raising my family to be in the same community that my family called home and are providing for all those generations. The recipient of the 2023 Anne and Neil McArthur Research Award is Dr. Lawrence Mbuagbaw. I'm going to say Dr. Lawrence because I don't want to have to butcher that. I apologize. Dr. Lawrence is the director of the Biostatistics Unit at the Research Institute at St. Joe's. He received his Doctor of Medicine degree at the Faculty of Medicine and Biomedical Sciences in Cameroon, West Africa. He then received his Master of Public Health degree at the Hebrew University of Jerusalem, followed by a PhD from McMaster University. Dr. Lawrence's research interests specialize in biostatistics and research studies through the lens of public health. He has authored over 300 peer-reviewed publications, leading to significant contributions to the study and understanding of the intersection of infectious diseases, research methodologies, and healthcare improvements. Dr. Lawrence is the co-director of Cochrane Cameroon, an international independent and nonprofit network whose mission is to support evidence-informed decision-making in healthcare through relevant, accessible, high-quality systematic reviews and other evidence syntheses. These publications are intended for all healthcare researchers, patients, healthcare professionals, researchers, patients, and caregivers. A senior editor and pilot, he has also served on various committees, including the Guideline Development Group of the World Health Organization, the Ontario HIV Treatment Network cohort study, and the Adherence Expert Review Panel of the Bill and Melinda Gates Foundation. I am so pleased to be here today and to listen to Dr. Lawrence's presentation today and introduce you to our 2023 Anne and Neil McArthur Research Award winner, Dr. Lawrence.
Good afternoon. I had to check the time to make sure it was after 12, so I could decide whether I should say good afternoon or good morning. So welcome, everybody. I am extremely honored to have all of you here, and thank you so much for coming to see my presentation. I had a lot of difficulty putting these slides together simply because the work I do involves supporting several other people in their own research, and therefore I don't spend a lot of time doing my own research. And also it means I get involved in several different projects. So when I was faced with coming up with a title for this talk, instead of trying to think of one myself, I just asked ChatGPT what to do. And this is the title that ChatGPT gave me: Empowering HIV Care, Navigating Mobile Health Solutions, and Tackling Drug Resistance. So based on what ChatGPT proposed, I put together a set of slides to present to you today. I do have some disclosures, including some which Anne has kindly listed. I'm involved with the Cochrane Africa Steering Committee. I'm the Cochrane Cameroon Co-Director. In all of these places, I have no financial conflicts of interest. I have played several roles with the WHO guideline development groups as a systematic reviewer, technical resource person, a reviewer, and a methodologist. Sometimes these roles are paid or unpaid. And I have done paid consultancy for study design, data analysis, and reporting for Janssen, Bayer, and AstraZeneca. The work I'm going to present here has in part been funded by the CIHR, the World Health Organization, the IDRC, the Ontario HIV Treatment Network, and the Research Institute of St. Joe's. So when I started thinking about my research, the first thing that came to mind is that it's a crazy quilt. So many interconnected parts, and it's hard to put them together into a consistent narrative. So the presentation today is my best effort at putting things together and trying to understand why I do the things I do and where it has led me. So in my work, there are several common themes, all of them mostly revolving around HIV. There's mother and child health, there's mobile health, there's mentorship, there's research methodology, and there's health equity. And there are a few other things which I shall not mention because we will not have time to talk about. And for most of these, I will only mention in brief, but I'll try to put everything together in a coherent narrative. So first of all, I will start with mother and child health, seeing that Mother's Day is coming soon. This study, Complications of the Postpartum at the Yaoundé Central Hospital, is the study I did for my MD degree. Where I did my MD, you have to do some research and present that as part of your thesis, which accounts for 50% of your graduation grade. So I was interested in looking at the prevalence of complications to the postpartum. So after a delivery, how many women have complications? And what we found was that about 12.4% had complications. Midwives did most of the deliveries, and most of the complications we found happened in the deliveries that were conducted by midwives. And then several of the women did not come back for the 6-week postpartum visit. And it turned out this was because either they had clinics closer to where they lived and they just happened to go into labor in some other area and they had the delivery there, but then they went home, or they just chose not to come back for the 6-week visit because they were fine. So this led to two contentious issues among my panel and jury. The first was whether midwives were responsible for all the complications. And it took a lot of back and forth for me to explain that, well, because midwives did most of the deliveries, it's only normal that most of the complications will be found among the midwives. And the take home from this was that if you're building capacity or developing any intervention to improve postpartum care, you should target midwives because they are at the forefront of this activity. And then the next other contentious issue was whether you can complete a medical consultation by phone. So some of the panel members were not happy that for the women who didn't show up after 6 weeks, we gave them a phone call instead of asking them to come in. And at this time, the term mHealth had not been developed. The term eHealth did not exist. And I started asking myself, what kind of healthcare can we reasonably provide to people who need help using mobile health services? And that's where my interest started shifting towards mHealth interventions and also looking at ways in which you could improve research methodology for other people who did not have a clear understanding of how research worked. So I continued doing mother and child care, and my first posting was in a remote part of Cameroon, in a in a hospital called the St. Teresa Catholic Hospital. And it was a busy time. And this is a picture of the night where I had to do 3 C-sections in the same night. And I'm particularly proud of this day because I don't think I'll ever get a chance to do a C-section hat trick ever. But luckily, all mothers and babies came out well, and they were also happy to join me and take this picture because it was interesting. It was unique. And obstetricians may not tell you this, but being able to do a C-section is very empowering. You have the life of somebody in your hands, not just one person, but 2 people, and you're responsible for saving both those lives. And it made me happy because I felt like I had the power to support my family. If my wife was in labor, I could step in and support the C-section. I could do what was needed. I had that power. But it turns out when my second daughter was born, the one in pink, who is going to be embarrassed in a second, I was in Israel. So so I couldn't be there for her delivery. And I got really concerned because I was thousands of miles away and I couldn't provide any support if there was any condition. So that's what pushed me to continue doing research in mother and child health. So while I was in Israel, this paper is actually the paper from my MPH thesis. And I tried to develop a new way of measuring antenatal care, a new way which would be more useful in predicting what the delivery outcomes would be. And we found out that if we measure antenatal care using the timing of the visits, so first visit in the first trimester, last one in the last trimester, and then you also count the number of visits, at least 4, and the person providing care. So care has to be provided by qualified healthcare personnel. And then it leads to women delivering in health units, which is a problem in low resource countries where many deliveries happen outside of health units. It also leads to the presence of a skilled worker at birth, and also the delivery of babies with normal birth weight. So this was very interesting and very nice finding. But then I got interested in other stuff, which was more of a distraction, but also something which I was curious about. It turns out the weight of a baby can predict their adult health outcomes, right? Low breath weight babies tend to have worse outcomes. Babies that are born too heavy also tend to have worse outcomes. But if you're trying to do research on this topic, you may not be able to find the records. Records are missing for several birth weights. So in some countries, what they do is they ask the mother how much the baby weighed, or was it a big baby, was it a small baby? And then there's research trying to determine if mothers can tell exactly what the size of their children were. So I did some work on that in Cameroon, and we tried to see if women could recall the birth size and use it as a proxy for birth weight. And it turns out in Cameroon, women cannot remember what their baby sizes were. There was absolutely no correlation, contrary to other countries where women can remember all the birth sizes of 7 children, right? So we absolutely need to capture the records firsthand. We can't rely on recall. So I continued doing work in this area, and I did a systematic review looking at ways in which we can improve antenatal care coverage, because my prior research had shown that antenatal care coverage is good if the antenatal care is done properly and then the women have better outcomes. So I conducted this Cochrane systematic review, and the interventions we looked at were all over the place. So we had to group them into single versus combined interventions. And we found that the single interventions do improve some outcomes, and combined interventions also improve some outcomes. But the bottom line for this is that this work went on to inform WHO guidelines. And it was the first time that I ever had work that was, that informed high-level policies and was cited in a big way. So I thought, okay, this is good. Maybe we should continue doing this. But then it turns out there were other more pressing issues. Now I had all my kids, and I was a little bit distracted from mother and child health. And in the place where I worked, HIV was a big issue. And I was running an HIV clinic at the time. So my research started shifting towards HIV. But the real reason why I shifted towards HIV was because of my mother. She was one of the first licensed prescribers of antiretroviral therapy in Cameroon. This is in the early 80s, back when many people did not know about HIV. So she dedicated a lot of her time to providing care for people living with HIV and doing research on HIV, and also teaching people about HIV care. She passed in December, and this presentation is dedicated to her memory. In the clinic where I worked, we were tasked with determining if people were ready to start antiretroviral therapy. At the time, you have to wait for the person's viral load to be high or for their CD4 count to be low, and then you start them on treatment. But when you have to start them on treatment, you have to determine which treatment you're going to start them on. And at the time, it was triple therapy, where you are supposed to give them 1 non-nucleoside reverse transcriptase inhibitor and 2 nucleoside reverse transcriptase inhibitors. And of the non-nucleoside reverse transcriptase inhibitors, we had 2 options, efavirenz or nevirapine. And it wasn't clear which one you were supposed to give. So I asked around and nobody could tell me. And I was fortunate to meet a colleague who said, well, this sounds like a good question for a systematic review. I said, okay, I know about systematic reviews. How can I do this? Where can I get support from? And he said, well, there's a program called the Review for Africa program, where if you are accepted, you get to be mentored by a group out of the South African Cochrane Center, and they'll help you complete your systematic review. So I registered for this program, and on the left is the mentor I was allocated. His name is James Elam. He's a pharmacologist, and he helped me get through the systematic review. But it turns out during this program, I was also fortunate enough to meet Professor Jimmy Volmink, who received an honorary doctorate from McMaster University recently. And we started doing this systematic review, and it went extremely well. I completed that systematic review, but the reason why I put Jimmy up there is because he introduced me to Lahana. I told him I wanted to do a PhD, and he said he didn't have any opportunities, but he knew somebody in Canada who might have opportunities. So he connected me to Lahana. I reached out to Lahana, and we started working together. And this is the first time we met in Toronto more than 10 years ago. I came as a postdoctoral fellow. It was a long distance mentorship, and I visited Canada twice during that time. And we enjoyed the mentorship relationship so much that we wrote a paper about it. And hopefully it can guide other people who are interested in setting up long distance mentorship relationships. And this became particularly more relevant during the COVID pandemic, where everything had to be done long distance and online, and people were able to seek guidance on how to set up a relationship like this electronically. So the research I wanted to do was simple, at least I thought at the time. So the idea was, we've determined that which of the drugs, efavirenz versus nevirapine, people should use. And nevirapine was cheaper. Efavirenz had psychological side effects. Nevirapine had skin side effects, but they were both equally effective. So now that we know which drugs to give people, the question is, are people actually taking their medication? And at the time, antiretroviral therapy was not what it was today. There were many pills, and the pills were burdensome. And it was hard. Most of the patients I had concerns with adherence. So my idea was, I forget the name of the thing, but there's the little bar that scrolls down during the news. And my idea was, I should put my message in there so that whenever anybody's watching TV, it just shows, remember to take your medication. And then, you know, it'll sort of improve adherence in some way. Now, this is me talking from never having done any real research. And I thought, well, this is how we should do it. But it turns out if you do it that way, there's no way you can measure what you're doing, because there's no way you know who's watching what channel and who is watching TV at what time. So it didn't really work. And that's where Lehana came in, because Lehana said, we shouldn't do it that way. We should do something more targeted. And the best way to reach people is to send them a message on their phone. Mobile phones were becoming more and more ubiquitous. So we decided to do the Cameroon mobile phone SMS trial. And that's what our poster looked like on the left. And we invited people to take part in the study. And then we had a certain number of messages which we sent out. One would read something like, hello, you are important to your family. Please remember to take your medication. And we ran this trial, and it was a very successful trial, one of the first mobile health trials to be run in Cameroon. And just for context, we also looked at the trends and factors associated with antiretroviral therapy adherence in Cameroon. And you can see that in some studies, it was reported to be low as 10%, in some as high as 95%. But the graph in blue, the line in blue shows the reduction in costs. And the red line shows adherence rates to antiretroviral therapy. And this is just a suggestion that income has something to do with it. The price of the medication has something to do with it. And as the price of antiretroviral therapy went down, people's adherence to medication also went up. So income is a key factor, and it'll come back again further down on my slide. So remember income. It was a good study, and it actually got some press in Cameroon, which is also the first time I was mentioned in a newspaper. Or not mentioned, it turns out only the director of the hospital was mentioned in the news article. But I knew it was my work and I was proud of it. So I don't mind if somebody took credit for running the hospital in which the research was conducted. So what happened with the study was, prior to setting it up, we did a qualitative study to ask people what kinds of text messages they wanted to receive, because this was new technology at the time. Nobody had done research with text messaging. So if you want to send people a text message, what exactly should be in it? Should it be motivational? Should it be inspirational? Should it be contemporary? So we went with motivational and contemporary based on what people wanted. So people wanted things like Merry Christmas, remember to take your medication, or you know, Happy Women's Day, remember to take your medication. And so we modified the messages according to what was happening at the time. And that's information we got from the qualitative study. And then we ran the trial, we completed that. And then we also used some of the data that the people were sending back. So the idea was, our platform allowed us to send messages and receive responses. So even though we did not anticipate responses and it wasn't part of our research, people were responding to the messages. So we collected the information that people were sending back to us, and we analyzed it. And it turns out people really liked the messages, and they really just wanted that open communication channel with healthcare beyond their scheduled visits. So that was very exciting. And then we faced some challenges in setting up an RCT in a place where they're not familiar with RCTs. People don't understand what randomization means. So we wrote a neat paper about that. And then upon reflection, we realized that, well, we've done this as researchers, but if it has to be implemented in the real world, and then we might need somebody else to do it. And we didn't think it was appropriate to put that burden on nurses. So we started investigating how community members themselves could actually manage and run a text messaging program. So that was the output of that bit. And we put all of this data together, and we started identifying other similar research done in other parts of the world. So we were able to contact some of the authors, and we got some of their data and we put it together. So we put together 3 trials, and we did an individual patient data meta-analysis of those 3 trials. So what we found was that text messages were effective. Their effect depended in part on level of education. So now we have income and we have level of education. And the other thing which we found, which was interesting, was that it's the weekly messages that work, not the daily messages. So lesson for everybody here, texting daily is too much. People want once a week messages. So that, at least that's what we found in our research. So now we have 2 socio-demographic factors we're working with. We have income and we have level of education. And then people also wanted interactive messages, right? They wanted to be able to respond to whoever was messaging them. Again, this work was used to inform guidelines in the US and for the WHO. So it was very good to see. And now the literature has evolved. We have gone beyond regular text messaging with GSM. And now we are using Wi-Fi and all sorts of apps. But at the time, this was what we had, and it was very basic, and it was shown to improve adherence to medication. So at this time, I had started living in Canada. So I started shifting my interest towards the things that were happening around in Canada. And some of the literature suggested that if you're trying to improve the HIV care cascade, a lot of the interventions shown to work were actually tested in low-income countries. So there's limited knowledge about what should work in high-income countries. So I decided to summarize some of that evidence, and we did a systematic review on strategies to improve the 3 bits of the care cascade, which we thought were interesting: initiation of treatment, adherence to therapy, and retention in care. So when we put all these data together, we had close to 250 trials, nicely curated, and we just couldn't leave them like that. So what we did was we created a database, and I used that database to inspire my students to find topics for their work. And some of my students have used that database to complete MSc thesis and PhD thesis work. And after putting the database together, we found a lot of interesting things. First of all, there's no uniform definition for retention in care. Everybody defines it how they want, which makes it challenging to compare studies and to compare jurisdictions. And then we also found that even the term engagement in care is very loosely defined. When people say people are engaged in care, it's not exactly clear what they mean. And we try to unify some of these definitions in this paper. So I'll talk a little bit about the Cascade database because it's an open resource which is freely available for anybody to use. It's a repository of clinical trials which we have been updating. I shouldn't say we, I should say Nadia has been updating. And it's curated by income level, vulnerable population, who delivered the intervention, the setting in which it was delivered, the intervention type, and the level of pragmatism. So the idea is that if you're looking for interventions delivered by clinicians, with a few clicks, it will pull all those interventions for you. We updated it in December 2023, and it includes close to 350 trials published since between 2015 and 2023, and it gets close to 10,000 visits per year. So it's an interesting resource that many people are using. So now we have this data, but how does this affect our work locally? The next thing we did was we developed a mixed method study where we got all the interventions that were shown to work in improving initiation, adherence, and retention. And we asked health workers in clinics in Ontario whether they were actually applying these interventions. And if they were not applying the interventions, what were their barriers to using these interventions? So we spoke to a decent number of people, nicely spread out around Ontario. And this table actually shows where you see green means the intervention is shown to work in the literature and is also implemented in the clinics. Where you see yellow, there's a discrepancy. It means either it doesn't work in the literature and is implemented in clinics, or it works in the literature and is not implemented in clinics. So imagine how pleased we were to find out that mobile health was one of the interventions that was consistently shown to work in initiating treatment, adherence to medication, and retention in care. And that was applied in almost all the clinics that we worked in. So that is my way of trying to tie in mobile health with the care cascade research that I'm doing. And then we also asked them what their barriers and facilitators were to implementing all of these interventions. And again, we were pleased to see that one of the barriers and facilitators which came up was, virtual care. Many people from the health worker perspective and from the patient perspective thought virtual care was facilitating their ability to engage with their HIV care. So again, it shows that there are several opportunities with mobile health that we can continue using as we have been using. And a lot of these became apparent during the pandemic and during the lockdowns. So I will now switch to the other things which happened after this. So the previous slides have emphasized adherence to medication and adherence to care. But the truth is the value of adhering to medication only exists if the treatment really works. And in people who have drug resistance, treatment doesn't work. They have a strain of the virus which prevents the treatment from working. So as of 2015, the WHO or UNAIDS decided on a new policy to scale up antiretroviral care, antiretroviral treatment. And what they did was, instead of waiting for people to have a low CD4 count and a high viral load before they start, they decided that as soon as you're diagnosed with HIV, you're eligible to start treatment. So unfortunately, this scale up of antiretroviral therapy also led to a rise in the prevalence of HIV drug resistance. And the drug resistance I'll describe here may exist in one of three forms. There's transmitted drug resistance, which means you got infected with a strain that was already resistant. There is acquired drug resistance, which happens when you do not take your medication as prescribed at a suboptimal dose, and then you develop resistance. And then there's pre-treatment drug resistance. Here, it really doesn't matter where your drug resistance is from, but the idea is that it exists before you start treatment. So if it exists before you start treatment, it's problematic because the treatment is bound to not work, right? And people could have pre-treatment HIV drug resistance either if they started taking antiretroviral therapy and then they dropped out of care, or they received pre-exposure or post-exposure prophylaxis. And then children who also received antiretroviral therapy to prevent vertical transmission from their mothers may also have pre-treatment drug resistance. So this creates a problem because the WHO did some research and they did a survey on 18 countries, and out of 12 of those 18 countries, drug resistance to efavirenz or nevirapine, which are the backbones I have earlier mentioned in starting tritherapy, was greater than 10%. And generally speaking, if more than 10% of the people have resistance to a drug, you probably shouldn't be using that drug because it means treatment wouldn't work in 10% of the population, right? But then based on knowledge about key populations who face discrimination, isolation, and limited access to care and criminalization, we suspected that drug resistance would probably be higher in these groups. And the key populations, as defined by the United Nations, are men who have sex with men, people who inject drugs, sex workers, transgender people, and people in prisons. And we thought the prevalence of drug resistance will be likely higher in these groups. And this has implications for the choice of first line of treatment, because if the prevalence of drug resistance is high, and then you can't give them the same things. So the only way to solve this problem is to do a drug resistance test before they start treatment. But drug resistance tests are expensive and they are not done everywhere in the world. So this led us to several research questions. The first is, does doing a drug resistance test actually improve outcomes in people living with HIV? What is the impact of having drug resistance? And what's the prevalence of pre-treatment drug resistance in the key populations which we have listed above? So here's the first question: does resistance testing improve outcomes in people with HIV? In order to answer this question, we decided to do a Cochrane review, which we completed. And what we found was that all the studies reported people failing treatment. So these are people who have started treatment and they fail treatment and then they get a drug resistance test. And we didn't find any data on people with pre-treatment drug resistance. And there was no impact on death whatsoever. But then if you did have a resistance test, it reduces your chances of having virological failure. So there was some benefit to resistance testing, but we only had data on people who had already started treatment and were failing. We had no information on people who hadn't yet started treatment. So this created several issues. Now we need to know the impact of drug resistance in people who are just starting treatment. But there is an ethical question. You can't randomize people to receive drug resistance versus not drug resistance, because there are already some parts of the world where drug resistance at initiation of therapy is routine care. So you can't refuse to give people routine care. And then also a lot of the people who have drug resistance have other risk factors which may impact their outcomes down the line. Like some people may be injection drug users, so men who have sex with men. And then there's also the problem of, even if you give them a resistance test and prescribe the right medication, if they don't adhere to that medication, and then their outcomes will be equally bad, right? So it's a challenging question to answer, and it's something that we can't answer with RCTs. So we still have a partially answered question. So we have to be ingenious about how we try to answer this question. So we tried the next question, which is the clinical impact of pre-treatment drug resistance. First thing to note is RCTs were not possible in treatment-naive people, as I have mentioned earlier, because it would be unethical to randomize them to a no resistance testing group. And prospective knowledge is not ethical, in the sense that if you know somebody has drug resistance, you have to do something. You can't just observe them, right? And then the other challenge we faced was that observational studies are poorly indexed. So they're not like trials that have to be registered and can be found all in the same place. Observational studies are fairly challenging to find. And also there is overlap in the large cohorts. So there are several large studies, large cohorts of people living with HIV that have been followed up. Some of them are in Africa, some in Asia, some are cross-continental. And then when you start looking at the studies that have been published from these cohorts, sometimes it's the same participants, their data published by different people. So you have to make sure that the overlap in the cohorts is limited. So that said, we went on to do this systematic review, and we found observational studies, 50% of them were found by snowballing. We just asked people if they knew studies and they sent us what they had in their personal libraries. And the way this worked was that we used retrospective cohort studies based on stored blood samples. So what happens is people are enrolled in a study and blood samples are taken at the beginning, and then they are followed up over time. And then at some point, someone says, well, what would the outcomes have been if they had drug resistance? So we can go back to the stored blood samples and check if they had drug resistance, and then estimate the risk of virological failure or death in the presence of drug resistance. In this case, the knowledge was not prospective, right? Because we went back in time, sort of, to find that information. So what we found was that people who had drug resistance had almost a 3 times odds of having virological failure or death. And this is the clinical impact of drug resistance. If you have drug resistance, it's very bad for you, and your likelihood of achieving virological success and survival is low. So armed with this, we went to see what the prevalence of pre-treatment drug resistance was in key populations. We did another systematic review, and we identified 218 studies with 332 data points with close to 60,000 people. And it included sex workers, men who have sex with men, people in prisons, and people who inject drugs. And there was only one study in transgender people, so suggesting a huge knowledge gap there. So what we found, again, was not surprising, but equally alarming. And if we set the threshold at 10%, right, we can see that in sex workers, the prevalence is much higher than 10%. In men who have sex with men is equally higher, and also in people in prisons, suggesting that everything we're doing in terms of first-line therapy should just not be used in these populations. And the conclusion is that pre-treatment drug resistance is higher in key populations. So all this work was done in collaboration with the WHO, and it helped inform the 2017 guidelines on the response to pre-treatment HIV drug resistance. And essentially what they say is, if you're able to get nationally representative pre-treatment drug resistance data and pre-treatment drug resistance to efavirenz or nevirapine is greater than 10%, and you can introduce something other than efavirenz or nevirapine, you should go ahead and do it, right? And if you can't, and then you should consider introducing pre-treatment HIV drug resistance for everybody, which is the challenge in low-income countries because they can't give that to everybody. And since we had a number of unanswered questions, we decided to follow this path to its logical end, because what we have in the red box, consider introducing pre-treatment HIV drug resistance testing, is exactly what happened in Ontario. So in Ontario, we have a beautiful natural experiment where in January 2014, there was a policy change to routine resistance testing, which means everybody who's diagnosed with HIV gets a resistance test. So what happens is we have a period of time before everybody had a resistance test and a period of time after everyone had a resistance test. And we got data from ICES and from Public Health Ontario, and we conducted an interrupted time series to see what the population level impact of resistance testing was. And our outcomes were mortality, hospitalization, and emergency department visits. What we found was equally interesting. There was a reduction in mortality after 2 years of follow-up, but no change in 2-year hospitalization or 2-year emergency department visits. So we have a great policy that reduces deaths, and we know that the prevalence of pre-treatment drug resistance varies among key populations. So it's unclear exactly how we should apply this policy, what the policy means, and who is best served by the policy. So we're wondering what it looks like on the individual level. We have shown that pre-treatment drug resistance testing reduces mortality on the population level, but on the individual level, what exactly does it look like? We were fortunate to be able to, in addition to data from ICS and Public Health Ontario, we got data from the OCS. So the OCS is the largest cohort study in Ontario, which includes close to 5,000 people living with HIV. And we screened the data and we ended up with about 1,800 people, of which close to 50% had received an HIV resistance test and the others hadn't. And we had data from 2005 to 2018. So we looked at the association between resistance testing and virological suppression. And we found, oops, oh, there. And we found some interesting things which we put on a forest plot, but I wouldn't bother you to learn how to read forest plots today. So I have summarized it for you in plain English. So the people who were more likely to have viral suppression or suppress their virus were the older people and people who had a non-heterosexual orientation. And the people who were less likely to have viral suppression were those having less than high school education. So another socio-demographic factor comes in. We have education, and now we have education coming up again in addition to income. And then we looked at the association between resistance testing and death. And what we found was that older people were more likely to die, and the people who had less than a university education were also more likely to die in the presence of a resistance test, and also those who had poor adherence. And this ties in with everything we have seen, right? That there is a role of adherence in terms of your outcomes after a resistance test. And then people who inject drugs were also more likely to die. The people who were less likely to die were the people who had higher incomes. Again, income comes in as a factor in all of this. So we have income, we have level of education, we have adherence, and we have key populations like people who inject drugs. So I will pause here and try to put everything together, because what we have seen is that in order to improve adherence, you can use a mobile text message to improve adherence, which will end up improving survival. But we also found that the mobile text messages work best in people who have a higher level of education. And then we also looked at drug resistance and whether resistance testing can improve outcomes. And we found that income and education also play a role in some of these factors. And people who inject drugs are also a key population, a socio-demographic variable, which impacts their outcomes. So hopefully this gives you a clear sense of how I put things together in my life to stay sane. And it helps to see that the same themes keep repeating themselves in different aspects of research. So there's one of the common themes which I mentioned earlier was health equity, which is a huge part of my research, which I am not going to talk about today because it's a massive, lovely can of worms. And I am giving a plenary about it tomorrow at Research Day, HAI Research Day at Sheraton. So if any of you is available to come, it'll be probably more exciting than anything I've ever presented before, except this one. So one of the main takeaways from this was that a lot of the studies were not designed to estimate prevalence, right? People would run their studies and then we'll take the study and we'll try to pull out the prevalence data from there. But these studies were not really designed for prevalence. And then there's a lack of standardized methods to interpret resistance. The appropriate way to say this would be that there are several standards to interpret drug resistance. So there's a French group that has their own approach. There's the WHO list, there's the Stanford list as well. So this sort of creates discrepancies in when you're trying to pull data from different studies. And then there are several regions from which we had no data, which points to criminalization. For example, in the Mediterranean WHO region, we did not find any information on commercial sex workers, but it is unlikely that none of them exist in that region. Likewise, in the African region, we found no data on men who have sex with men, suggesting that because of criminalization, there is important data out there which we are unable to capture. And then we also found that there was no data on the newer drugs, since there are newer drugs and nobody has really checked to see if there's any drug resistance to them. And it's also less likely, but it's emerging now. And some of the studies were really reported very badly. So being the good soldiers who we are, we concluded that guidelines were needed for studies of HIV drug resistance. We were displeased with the lack of these guidelines. So we set out to study exactly what the problem was with reporting. So in this study, we looked at the different things that were reported in studies that would be of interest to anybody reading a paper. So we looked at study level data, participant data, and information on resistance testing. So the points to the left indicate that it was really reported very poorly. So almost no studies reported a sample size justification, right? Many studies did not report the proportion of the people included, place of residence, about half reported ethnicity. But then the two key things which drew my attention were the following: level of education and income. it's coming up again, and it's the least reported thing in studies of HIV drug resistance. So clearly guidelines are needed so that when people report prevalence of drug resistance, you can see what the correlates are with socio-demographic characteristics. So we were successful in pulling this checklist together, and we did create a checklist published in Lancet HIV, and it looks something like this. I didn't take enough time to think about the acronym, so I ended up with Cedric HIV. It's a boy child, so to speak, and that's why everything is in blue. So there is Cedric, and we created a nice website for Cedric, and people have already started using it. It's been cited by 2 papers already. And we also translated it into several languages. It's available in French, Portuguese, Chinese, Spanish, and Italian. So now if we reflect on all the things I have spoken about, we started off comparing efavirenz to nevirapine and trying to improve adherence to these medications using mobile health. And we've shown that mobile health works and that virtual care is an important facilitator in the HIV care cascade. But now we also have pre and post-exposure prophylaxis. These are entities which did not exist at the time I started doing HIV research. And essentially pre-exposure prophylaxis is treatment taken by people who are not HIV positive to prevent infection in the event of an exposure. And we've also shown that there are disparate levels of HIV drug resistance, suggesting that sweeping population level policies might not be the most appropriate. And while we started off trying to choose between efavirenz and nevirapine, now we have even better alternatives. So people can use dolutegravir instead of any of those 2. And it sort of makes all the previous work obsolete, even though it builds into what we have now because there are things that we can learn. And then there are newer drugs. There are long-acting antiretroviral therapies, which are injectable. You need an injection once every month or every 2 months, which means we have to redefine how our understanding of adherence. Now it's no longer a pill, but it's instead an injection that people will take. So that said, because of the changing landscape of HIV research and practice, we still have several other things that we are planning to do. Now that there are newer drugs replacing efavirenz and nevirapine, and they've been out there in use for a while, there's emerging drug resistance to dolutegravir, right? So there is actually work going on in the WHO trying to determine the best ways to measure dolutegravir resistance so that we are ready in case it becomes more widespread. And then there's some work I'm doing in terms of tailoring approaches to delivering HIV care, since we have shown that there are several socio-demographic factors that influence your outcome when you have HIV. So there's a tool I'm developing called the HIV Case Management Acuity Assessment Tool. The research is ongoing. We're hoping to develop a tool that when people with HIV present for HIV care, you can go through all the different factors that might prevent them from engaging in care, including housing issues, transportation issues, nutrition issues, sexual and reproductive health, and legal issues as well. One of my students suggested that we update the Cascade database to include pre-exposure prophylaxis and post-exposure prophylaxis, which is something that we might consider doing because now it is an important part of HIV care, even though it's not necessarily provided in people who have HIV. And obviously, the next thing we have to do is to continue monitoring use of our checklist and promoting its use as well. So I do have some end credits. And there's also a post-credit scene, like all decent movies these days. I would first of all like to thank the McArthur family for their kindness and for this award and for developing it 20 years ago. I will state the date once we know that date. And I also want to thank my friend and colleague, Andrew Costa, for nominating me for this award. He was kind enough to say, I've looked at your CV, I think you can do this. And I was like, okay, I hope. And it turned out to what we have today. So I'm grateful to him. My work would not have been possible without the support of several mentors. So on the top row, I put my supervisors for formal academic work. And Lehana appears twice because he did it twice. He was my postdoc supervisor and my PhD supervisor. It is not a mistake. There are several other people who have helped me along the way, many of whom are sitting in the room here today, and I am very, very grateful to them. I am also grateful to the collaborative spaces in which we work. At HEI, people are nice and collaborative and supportive, and everybody is a mentor in their own way. And sometimes mentors Mentorship is a conversation over coffee. It's meeting somebody in the hallway and they just say, keep on doing what you're doing. They don't know what you're doing, but you should keep on doing it. And that's the thing, right? Keep on doing it. Never stop, never give up. That's what I like about HEI. And obviously the Research Institute has extremely wonderful people that I really love working with. And I was telling my family the other day that even though with all the buzz about this award, there is one picture of me. We took 80 pictures. We did a full photo shoot the whole day with that lady over there, and it was fun. So hopefully we'll get to use those pictures one day. I also, I want to acknowledge everybody at the Research Institute, all the staff and people who work there. And I also want to acknowledge the support of the Biostatistics Unit. The staff I work with are extremely lovely to work with, and they make work enjoyable. I started off my presentation with a crazy quilt, and I do have another one. So this is the mosaic of my current students. The past ones at the bottom, they built on me when they got their degrees. But yeah, these are the people who keep me on my toes because the topics they're working on are extremely diverse and extremely important. And it takes a lot of work to keep up with them in terms of what they're doing. And it also makes me work as hard as I have to. And then many people often forget the genetic support. A lot of what you do is from your genes. So while there is nature and there is nurture, I appreciate the nurture, but I also want to fully acknowledge the nature because these are the folks who passed on their genes to me. And that's what I'm working on. That's the blank plate you start with and you start improving things. So that's what I mean by genetic support. They gave me the genes and we're building upon those genes. And I'm very grateful to both of them. And obviously, they're the people who have to put up with me on a daily basis. My lovely family, they left work and school to show up here to support me. So I'm very grateful for them as well. And if I have any final notes, it is that teamwork and collaboration is the way to go. Work with other people, help other people, support other people. And also don't be afraid of the rabbit hole. When you find your white rabbit, follow it. Follow the research question all the way down the line and great things will happen. Thank you.
I'd now like to invite our Executive Director, Sarah Howe, to the podium.
Thank you so much, Laura. Thank you, Lawrence, for that unbelievable talk. I think I know you all, but I'm Sarah Howe. I'm the Executive Director of the Research Institute here at St. Joe's Healthcare Hamilton, and I have the privilege of closing out today's event. I just wanted to take a moment and again thank the McArthur family and specifically Anne for being here today and for their generosity, because without you, we wouldn't have this award. We wouldn't be able to celebrate some of our greatest researchers here at the Research Institute. So thank you very much. And then I want to take a moment and just recognize Lawrence's family again. Thank you so much for coming. And to all of you, our healthcare research and innovation community. I think it's really easy to put your head down and get taken in your day-to-day work, and to see you here today, taking that moment to learn and for me to be inspired is really important. So thank you very much for coming. I came to St. Joe's just over 2 years ago, and I've said a number of times that the breadth and depth of research here is just incredible. And I think, Lawrence, your talk is a great shining example of that. Thank you so much for taking us on your journey. I heard from you collaboration. I heard from you curiosity. And I think, I am not a researcher, but there are moments for all of us to follow that white rabbit and continue down those areas. So thank you so much for your inspiration. I have no doubt that this is not the last time we're going to hear from you and to celebrate your work or you as a researcher. So just once again, congratulations to you, Lawrence. And I look forward to seeing everyone out at the reception in the lobby. Please join us for some food, drinks, and some great networking, but we can collaborate as well. Great. Thank you.